Here's an example of how potentially inappropriate medication, or PIMS, are identified in the list, their recommendations, and the rationale behind them. The American Geriatric Society, or AGS, has these materials available on their website, although they must be purchased. However, you didn't hear this from me, but if you go out and Google the Beers list of inappropriate medications, you can get access to a variety of publicly available materials highlighting the contents on this list as well. In addition to just having the potentially inappropriate medications, it also lists situations with potentially inappropriate medications with disease states, so drug disease complications. The examples on here highlight central nervous system conditions and medications to avoid, a lot having to deal with those classes we previously discussed, including anticholinergics, benzodiazepines, and antipsychotics. The Beers list does identify 30 drugs to avoid in general, as well as 40 to use cautiously, along with those situational examples that we have as well. It also looks at drug-drug combinations that need to be avoided. And a lot of this, again, we come back to our CNS agents and trying to avoid opioids with benzodiazepines and gabapentinoids, more than 3 centrally nervous system active prescriptions. In addition to that, we also have some of our drugs that are used for UTI prevention or antibiotics, but some of the issues they can potentially cause as well here. And finally, with the Beers list, it also helps to address those metabolic changes that occur with aging, including kidney disease, as we see here, with recommendations based on renal function and drugs to avoid with chronic kidney disease. So it's a great list with lots of things to consider. In addition to the Beers list, we also have the stop-start protocol. This is some tools similar to the Beers list that were developed in Europe around identifying potentially inappropriate medications. And these are grouped by physiological symptoms and geriatric syndromes. STOP stands for the screening tool for older person prescriptions. So it's looking at identifying medications that can be discontinued. And the START stands for screening tools to alert doctors to the right treatment. So this is trying to avoid the start of potentially inappropriate medications. There is overlap between the stop-start criteria and the Beers list, but there's also some differences as well. Some of that might relate to the drugs available between Europe and the United States and some of our practices. However, studies have found that between both of these lists that the criteria are modestly predictive for adverse drug events, and that these criteria should be used in complementary fashion. Here's an example of start-stop criteria by system. Cardiovascular recommendations include keeping doses of digoxin to less than 125 micrograms, avoiding loop diuretics as first-line therapies, and CNS recommendations include issues with tricyclic medications due in large part, again, to their anticholinergic properties. Here's some of that data involving the start-stop protocol. Their studies found that half of hospitalized patients were on potentially inappropriate medications. By implementing the start-stop criteria, they were able to see a reduction in falls, reduction in drug costs, and most importantly, a reduction in adverse drug events, which improves quality and decreased costs of anywhere from 1/8 to 1/4. So a pretty good decrease there. So as I try and wrap things up here, we're running short on time. My apologies for maybe cutting into our Q&A time some here today. To summarize our presentation, when looking at polypharmacy, deprescribing, and medication management, it's important to consider what matters to the patient. We need to take their current status in mind and again, some of that quality versus quantity decision is a discussion to have between the patient and their family and the provider. Along with what matters, we need to identify potentially unsafe medications, look for those opportunities to deprescribe, and use those tools that are available with us to help with our assessment and deprescribing, as well as activating our patients to improve their medication adherence. And finally, the age-friendly health system with the 4Ms framework provides a great framework within the clinical setting to address medication management and how medications are connected to those foundations of the 4Ms, including mobility, mentation, and what matters.